All right, I think we are officially live. And I think Rachel's computer conveniently just died, and she's your moderator.
Nice.
But I can introduce you real quick for everybody. So, Dr. Chris Schriever, I'm sorry, am I saying that correctly?
Schriever.
Schriever, okay. Completed his training at the University of Iowa, earning a degree in microbiology in 1987. Upon completion, he remained with the university in the Department of, oh goodness, how do you say that?
Otolaryngology.
Okay, thank you. Conducting immunology research. After leaving the University of Iowa, Dr. Schriever continued his research endeavors, earning a biological science master's degree with an emphasis in micro and molecular biology from Northern Illinois University. His career continued as he accepted a position as a medical microbiologist at Swedish American Hospital in Rockford, Illinois, and he remained there until his acceptance into the University of Illinois at Chicago, the College of Pharmacy in 1995. After completing a 4-year Doctor of Pharmacy degree, Dr. Schriever continued his training by completing a PGY1 residency with the Chicago Veterans Administration Healthcare System, followed by a 2-year fellowship in infectious diseases at the University of Illinois at Chicago. He remained at the university as a research assistant professor until 2004, when he accepted a position as an infectious diseases clinical specialist at Loyola in Maywood, Illinois. Dr. Schriever remained at Loyola until the summer of 2010, when he returned to the University of Illinois at Chicago College of Pharmacy, the Rockford campus, as an assistant clinical professor, practicing at a community health center in Rockford. Dr. Schriever is certified as an American Academy of HIV Medicine pharmacist. In addition to his HIV practice, Dr. Schriever serves as the vice chair for the State of Illinois Drug Utilization Review Board and is a member of the state's Immunization Advisory Committee. His other interests include antimicrobial susceptibility testing, outcome studies, and C. difficile infections. So thank you so much for being here today, Dr. Schriever. Please go ahead with your presentation.
Okay, thank you for having me. I'm trying to figure out how to get the full screen so it presents a little bit better. Please bear with me 1 second. Okay, there. I hope everyone can see my PowerPoint at this point. One of the talking about the next the pandemic, and we've had God knows everybody's getting all pandemicked out. I wanted to go over some of the global pandemic of antimicrobial resistance that I think we're facing, and I think that's going to be one of our next big pandemics in healthcare. So for our learning objectives, I'm going to go over a little bit of gram-positive and gram-negative resistance, but kind of that 30,000 foot view. I'm going to focus
Dr.
more
Schriever,
on. Yes.
I'm so sorry to interrupt, but I'm not sure if your slides are advancing. Yeah, there seems to be a little bit of a lag. They just advanced. Are you sharing your PowerPoint presentation or are you sharing your screen?
I am.
I recommend sharing your screen itself. That was an issue I ran into earlier today rather than the PowerPoint and then just pulling up your PowerPoint.
All right, share my screen. Share entire screen. All right, there we go.
Yes. For some reason, that runs smoother.
Unfortunately, Identify is not letting me share. It's only letting me share a window. Let me try this entire screen.
Oh, there you go. We can see it. It's just until you pull up the PowerPoint, it looks a little wonky.
Okay. Is that better?
Do you have the PowerPoint up yet?
I do.
Oh, I can't see it. Shoot.
Boy, this is like a Southwest Airlines commercial. You want to get away? Um, it's not sharing. I don't know why.
No, if you'd like, I can. Are these the same slides that I have received? I can share
Yeah,
them too.
yes, please
Okay.
do.
I will give me 1 second to pull them up, and hopefully that'll go smoother. Okay, I'm going to share my screen and let me know if you can see it.
Yes, I can
All right,
see it.
great. Okay, then just tell me to advance when to advance to the next slide, and I'll take care of it.
Okay, next slide, please. Okay, that's me. Kind of talked about that. Next slide. Again, going to talk about resistance, gram-positive, gram-negative, kind of a global overview of it, and talk about really how we don't have a whole heck of a lot out there. I'm going to look at some of the factors and examine some of that are contributing to this resistance crisis, and kind of talk about how we're going to do best we can with what little resources that we have as far as antimicrobials. Next slide, please. Well, I think we're all kind of COVIDed out. I know that I've certainly, and everybody else has been very involved. And we've been hearing a lot about the COVID pandemic. And I was sitting and I was thinking, well, what's going to be our next pandemic? Is it going to be SARS? Is it going to be this new Delta variant that's coming? Is it going to be, I've heard rumors of a Gamma variant. Where are we going with this? And what's really going to be our next one? Next slide, please. And so what I started thinking about, and granted, it hasn't quite received as much attention as the COVID pandemic, but I started thinking about, as I was looking through some of my old lectures, the antimicrobial resistance that we're starting to see today. And we see little blurbs here and there in the press about the flesh-eating bacteria and some of these other articles. But it's always kind of simmering kind of in the background that this might be a little bit of an issue. And while it, again, hasn't received quite the prolonged attention that COVID has, it certainly does warrant, I think, some talk as one of the potential next big crises we're going to have in healthcare. Next slide, please. So what are the consequences of resistance? Well, naturally, once we start developing resistance, we have limited treatment options. So we look at some of our more common infectious processes, such as, and these are ones that are driven primarily in the outpatient setting, but our urinary tract infections, our bouts with community-acquired pneumonia, cellulitis, and all these. And once we start having limited agents to treat these infections, actually they're going to increase healthcare costs. Once these patients start becoming colonized and start having these multi-drug resistant infections and infections we can't cure, this is certainly going to limit their abilities to be able to have certain elective surgeries. One of the things that I'm thinking about is my mom has been living with us for the past month is knee replacements. Hip replacements, any other kind of elective surgery that we're thinking about. Can this resistance also affect cancer chemotherapy down the road? All in all, this increased resistance is certainly going to limit options that we have for treatment. It's going to increase morbidity as well as mortality. Next slide, please. Next slide, please.
There's a bit of a delay.
Okay, so when did we really start seeing and start noticing all these resistance trends? All hospitals are kind of acutely aware, and I realize the group that I'm talking to, everyone is very well versed in infection control and in infectious disease. So all hospitals kind of know what their surveillance data is, and they know that what they have for gram negatives and gram positives, and they've been watching the numbers kind of increase over time. Much of the focus and I think a lot of the attention started coming in the mid 2000s with MRSA. With MRSA, it was always kind of that infection that we saw. And methicillin-resistant Staph aureus, the first cases reported in the early 1960s, about a year after methicillin came to market. But we never really worried about it because that was the infection that was primarily in the hospital, and it was it happened with those people who were in there for long periods of time, and so on and so forth. In the mid 2000s, we started seeing this infection, but occurring in a community environment. We started seeing it in people who weren't acutely ill. We started seeing it in the locker room. In that report, I believe it was in internal medicine, Annals of Internal Medicine, that outlined the transmission of the bacteria between different members of a professional football team. We started seeing increase in prisoners, in prison populations, in daycare centers, in certain outpatient and ER settings. So now we're starting to see this more in those individuals that we don't think of that are going to have those resistant or multi-drug resistant infections. Kind of more or less, everyday individuals would be at risk. The National Nosocomial Infection Surveillance Report, and I'm going to make reference to that, but this really kind of gave us a little bit to look at as far as looking at everything and what we were seeing in the late 1990s and the early 2000s, and kind of what was the environment at the time. And what we started seeing was certain organisms. Again, MRSA, we were starting to see MRSA rates approaching 50%. Okay, so we've always kind of had that in the background, but we're starting to see these rates continually increase. Where now we're going to have to start using, drugs like vancomycin. We're starting to see organisms such as Klebsiella pneumonia, a member of the Enterobacteriaceae family, now becoming resistant to third-generation cephalosporins. And those agents, for examples, would be ceftriaxone, ceftazidime. We're seeing increased resistance to quinolones and also third-generation cephalosporins and Pseudomonas. We're also having reports of these multi-drug resistant organisms. And so for multi-drug resistant organisms, when I refer to those, I refer to, and it's just kind of a loose definition, but it's generally considered those bacteria that are susceptible to two or less antimicrobial classes. So this was kind of our first peek at really what's going on. Next slide, please. And here's a little bit of the data, and you can see from the data that vanco-resistant enterococci, that the increase we're seeing in that, MRSA, along with the decreased efficacy of the third-generation cephalosporins, not only Klebsiella pneumonia, but also to E. coli, as well as some other members of the Enterobacteriaceae family. We're also seeing Pseudomonas becoming resistant to quinolones, as well as carbapenems. And I'll talk a little bit about carbapenems in a few slides down the road. Next slide, please. So when we think of resistance is something that occurs naturally. We all know that. And I think of the survival of the fittest when I talk to students about this. That over time and during the replicative process, as bacteria or virus or fungi or whichever organism we're talking about, as they change their genetic material and as it gets altered, just because that normally happens in the replicative process, sometimes it can be altered in a beneficial way. And if it's altered in a beneficial way that allows that organism or bacteria to be able to replicate and make copies of itself in the presence of a drug, well, that's a good mutation. And certainly we do see that happen. And that's one way how resistance can develop. We can also see resistance develop by the spread of genetic material. And one of the a few of the main ways that we see is human-to-human contact. I consider us kind of, and I look at my children, and God, they really kind of are mobile petri dishes. But we think about the human-to-human contact. when we take the normal flora from one person and it gets passed to another, and sending that resistant bacteria to another individual. We can also see it genetic material spread by animals. We know that we want the biggest, the best, the strongest cattle that make the best meat. So what do? We end up giving them antimicrobials, and that makes them big and keeps them healthy. Those antimicrobials are eliminated environmentally. Where do those bacteria go? They come into contact with humans. So that's another mode of spread. We can also see the same happen with the production of food. So overall, it's really this misuse of antimicrobials and overuse, certainly in animal and food production, as well as poor infection control practices that are really driving a lot of the resistance we're seeing. Next slide, please. During this time, we have had, and I've alluded to the resistance we have with gram positives as well as the gram negatives. At least I have a few agents listed for gram-positive infections, and really within the past 20, 30 years, we've only had 2 novel agents come to market for gram-positive infections. And when I'm talking about novel agents, I'm not talking about taking a cephalosporin and adding another, modifying it a little bit to increase the spectrum of activity. I'm looking at something that kills the bacteria in a completely different way. So in the past 20, 30 years, we've had 2 agents that have come to production that have been really helped in the treatment of gram-positive. For gram-negative, very little. Actually, you're going to see that in the past 40 years, 4 decades, we have had no new agents with novel mechanisms of action come to market. So this is part of the problem. And thinking that we can all of a sudden flip a switch and we're going to get those the next day isn't going to happen. Next slide. So who are the players we're worried about? Next slide. I talked a little bit about some of the, naturally we see, again, resistance in bacteria, viruses, fungi, along with parasites. This talk's primarily going to be bacterial in nature. So with the gram-positives, a lot of the same ones that we've seen before. The MRSA, not so much as the inpatient, but this community-acquired MRSA. So we're starting to see MRSA outside of the healthcare system. We're also seeing Vanco intermediate and Vanco resistant Staph aureus. We've always had, that known that vancomycin is potent enough, and we can sit and debate that and how we dose it and everything else, but we always kind of knew that we had that in our back pocket, and it's been a fairly durable antimicrobial for Staph aureus for a good 40, 50 years. That stated, we're starting to see vanco-resistant isolates of Staph aureus. Now, there again, it's kind of good that we've had those couple novel agents come to market that we have as treatment options. VRE, as well as penicillin-resistant pneumococcus. So while there are a significant amount of gram-positives we're seeing, we do have at least a couple agents there. Next slide. Klebsiella pneumonia is one of the ones that I can think of, that and another member of the Enterobacteriaceae, E. coli that I would see back in my days of clinical microbiology. We would see that this organism, very much like E. coli, could gain resistance genes through a plasmid. And the plasmid encoded an extended spectrum beta-lactamase, or ESBL for short. And what the ESBL does is it encodes its extended spectrum easy for me to say, encodes an extended spectrum beta-lactamase that would render nearly all the antimicrobials, the penicillins and cephalosporins, inactive against that bacteria, with the carbapenems being the only choice of antimicrobial that still had significant activity against that. Since these were spread on plasmids are mobile carriers of genetic material, we also saw other resistance patterns occurring frequently, and those would be quinolone resistance. So it would travel and carry a number of resistance factors with it. Long and short, I always told my students, well, don't worry, not don't worry about it, but I said, well, you always have carbapenems to look for. You've always got that to fall back on for when you see one of these ESBLs. So just remember that. Next slide. So now we've got carbapenemase resistant producers that have been isolated in Klebsiella. KPC strains, Klebsiella pneumo carbapenemase producers. Now, the one antimicrobial, the carbapenem class that we had to fall back on, is no longer available. So we have much fewer options. We don't have any of the other beta-lactams. We don't have any of the other extended spectrum penicillins, and we don't have the carbapenems. What are our options? Colistin, tigecycline, aminoglycosides. I mean, when we want to think about an awful group of antimicrobials that really are kind of hard to tolerate, that's the group. When the aminoglycosides came to market in the 1960s from what I heard, and people were still using colistin at that time, it was told to me that everybody said, great, at least we have something that's not as nephrotoxic as colistin. So you can see that we have much fewer treatment options, and the ones that we do really aren't patient-friendly. The New Delhi metallo-beta-lactamase, similar broad spectrum activity like the carbapenemase. So we're seeing that we're getting these whole classes of the cephalosporins, carbapenems, and penicillins that we just don't have any activity. Any agents that have really good activity like the class of beta-lactams. Next slide, please. Besides the members of the Enterobacteriaceae family, Klebsiella pneumonia, E. coli, Pseudomonas is also frequently associated with widespread resistance. And it's the second most organism isolated in the hospital. And one of the issues with Pseudomonas as opposed to Klebsiella, number of mechanisms for drug resistance, porins. So we can so the bacteria has the ability to limit the antibiotic influx. Efflux pumps. It can, if it gets in the bacteria, it can pump it out. It also has a number of inducible enzymes that can modify different antimicrobials, rendering them ineffective. So with Pseudomonas, typically we see multiple mechanisms for drug resistance occurring at the same time. So because of this, we'll frequently see multi-drug resistance in Pseudomonas. Next slide. Acinetobacter, I consider this to kind of be very similar to Pseudomonas. It also has a number of the same intrinsic resistant mechanisms, and we've seen numerous outbreaks and typically the same multi-drug resistant isolates that occur in Pseudomonas, we can also see occurring in Acinetobacter. Next slide, please. So because of this, because we really have no drugs coming, in the market, Infectious Disease Society of America started this bad bugs, no drugs campaign. And it was kind of let everybody know, hey, we've got a bunch of increasing resistance. We don't have really any good antibiotics. We got to find a way for people to make antibiotics. We got to incentivize research and development. We've got to find other funding mechanisms to see if we can discover new novel ways of combating these organisms. Next slide. So when we look at the antimicrobial timetable, and I'll have a slide that'll show the development, we hit a pretty steady development of antimicrobials from the 1930s to the 1970s. And as we look at the slide, and we can see the lines that are going upward from the 1980s to the 1990s, we have MRSA, VRE, and fluoroquinolone-resistant Pseudomonas. So we can see from the 80s and the 90s, we have increasing percent resistance. Now, the line crossing over, we can see from 1990, companies researching antibiotics, 18. 2010, companies researching antibiotics, 4. And we look at the number of antibiotics approved in that time. And we can see that line is going in the wrong direction. So again, nothing new for gram-negatives in the past 4 decades, only a couple classes for gram-positives, same time period. Next slide. So this is kind of the perfect storm. We don't have the novel mechanism of action. We have R&D pulling out of this, not wanting to invest the money. So we got resistance up, drugs down. Next slide. So now I would consider this kind of an antibiotic drought. And how do we do it? And really, why did we get here? Next slide. So again, nice kind of steady stream of antimicrobial function or antimicrobial production in the 1930s all the way up to the 1970s. And then all of a sudden it just drops off with just the two classes in the early 2000s. Next slide. So why does R&D get out of this? This was my first question that I was kind of wondering. Well, if I was in R&D and nobody else is making antibiotics, well, I'll just make an antibiotic and I'll call it crisacillin and it'll kill everything, or crisomycin. I don't know. Add your suffix to it. But I would just make an antibiotic and I would have the only antibiotic. And I would make all this money. Well, we're really seeing what's driving R&D and the sales in the pharmaceutical company are those chronic conditions that we use, the Lipitor's and Viagra's. And I didn't pull them out to pick on them nor pick on Pfizer. I was just pointing out two very successful agents that have come to market that patients have to take every day. When they look at the cost of development of these agents, of any pharmaceutical agent that you're putting in there, versus the revenue return, antimicrobials always fare extremely poorly. The net value that they get for antimicrobials is never it is not close to any of the other chronic disease states agents we would consider using. Next slide, please. So when we do have that company that comes up and makes that antimicrobial, what do we do with it? Well, first of all, it's non-formula, and we don't want to let anybody do it. We don't want to order it. We don't want to do anything with it. It's almost like we put it under a glass shelf, and we put it really high up in the pharmacy, as long as it's room temperature, and we lock it up, and we cover it in glass, and we don't let anybody look at it. We don't let anybody use it. And typically, if we're going to use it, even in that sick patient, how long do we use it? Maybe 2 weeks. We could say, sure, they have an osteomyelitis and let's treat it 5 or 6 weeks. But I mean, that's it. That compared to the rest of your life. So I look as somebody that has a 401k, and I'm sure everybody else here does, and look at what's making money and where your money's going. I can't necessarily blame them. I mean, they have a business to run by everybody else. So why do it? Next slide. So because we have to realize that we have to find a new way to kind of incentivize, we've got to make somehow more profitable for pharma to do R&D, for researchers to look for these new agents. We really have to incentivize this to make the effort a little bit better for them. But in the meantime, what do we do? Well, one of the things that we can look at is we can try to anticipate what is going to happen before it does. So we can look at surveillance data, and certainly we can look at local surveillance data, and that gives us a little bit of an idea of what's happening in our backyard. But really to kind of assess what's happening everywhere. I mean, think about where we get our food, where we get, animals and everything else. It's a very global process. So we need to kind of expand our horizons and look without our community, our region, but look globally. We need to look at some of these resistance trends that we're seeing and determine, is it because of poor outpatient antimicrobial prescribing? Is it because of the food we eat? Is it because of the animals that we care for? Find some of these other factors and see if by controlling them, can we alter resistance? So by doing this and looking at some of these other databases and doing more advanced surveillance, we can look at some of these trends before they happen and before they start occurring. Then all of a sudden seeing it like right now, like, whoops, we've got 50% MRSA resistance. That stinks. Next slide. So the WHO, the WHO, and my students always call it the WHO, and it just drives me bonkers because the WHO is one of my favorite bands from the 1970s. WHO, World Health Organization, recently in 1925 launched a report on global resistance, and they termed it the GLASS report, Global Antimicrobial Resistance and Use Surveillance System. And what it does is it takes antimicrobial data globally from every country, from every country that's going to participate, and it looks at that in conjunction with the infection, along with the human and animal consumption within that region. Next slide. So currently there's 109 countries. Companies is wrong. 109 countries participating in the Global Impact Study. This has been increasing, and it might be up to 115 at this point. Lots of data, more than 3 million laboratory confirmed infections. The fourth report was released recently, and that was the 2019 report going through, released in 2020, and that's been kind of going through analysis. And we're starting to, and it's continuing to show the same process that we're seeing is resistance is going up. Some other interesting findings about whether or not income also affects resistance as well. Next slide. So the most recent report, the 2021 report, that despite COVID, most of the participating countries still ended up submitting the data, which is good, because this is a very robust database of information we have. As I mentioned, there appears to be some kind of increase that we're seeing in those, not only with the antibiotic use, but I brought in that disconnect with income versus resistance. Is this real? And what the report, just on the surface, and it's maybe too early to tell if there's a signal here, but we're seeing those individuals in lower socioeconomic places with higher resistance rates. Now, if antimicrobial use and everything else is the same, why would that be coming to the top? And right now, they say that they're not sure if that's a true signal, but there's going to be more to come on that. They're continuing to see the high resistance rates in very common infections such as UTIs. UTIs and the treatment of UTIs, we see a lot of antimicrobials used from the outpatient setting. That's really driving this. Bacterium resistance up to 50%, Cipro resistance in E. coli over between 30 and 40, and Cipro and Klebpneumo over 30%. 20, 30 years ago, Cipro used to, you could almost show the tablet to these organisms and it would just die. So we're continuing to see no break in this increase in resistance. Next slide. Carbapenemase remains a concern. And as I mentioned with some of the other pathogens, Acinetobacter, Klebpneumo with the carbapenemases, once that class falls out, we really start kind of losing that broad spectrum class that we could always kind of fall back on. But more importantly, that class that was more or less user-friendly and had a good therapeutic window for the patient, meaning that the patient didn't have as much toxicity with that class of antimicrobials. So in doing so, we have treatment options, some beta-lactam inhibitor combinations. However, that and the mechanism of action that it has always doesn't last as long as you'd like it to. Colistin and aminoglycosides, while they may have some activity, now we're starting to think of the agents that we're using really don't have that friendly side effect profile that we like when we treat our patients. Next slide. Other areas of concern: Neisseria gonorrhea is now considered a threat. My great story grandpa, when I was working as a medical microbiologist in the mid-1990s, we used to treat. You were still able to treat Neisseria with penicillin. And matter of fact, we would test every isolate of Neisseria we had for penicillin resistance. That has long since gone away, and it's almost assumed that every resistance of Neisseria could be or is resistant to penicillin. Ceftriaxone, well, we've started using that at the lower doses. Recently, we've had to bump it up to using 500 milligrams and even a gram once a day for treatment. We're continuing to see uptick in resistance with Candida species and bloodstream infections. Taking, again, this very robust database and insert and and figuring exactly where it falls and what we should be looking at and to better assess how to manage this problem is going to take a lot of time. I have a question. Could increased resistance in some countries be associated with OTC access to antimicrobials? Absolutely. I do not see why not. Again, when we look at that, they in these areas where we are seeing widespread over-the-counter use of antimicrobials, that's just going to go in with their consumption of antimicrobials. So while that wasn't mentioned per se exactly in that, I do not see why that would not be a contributing factor. Great question. Next slide, please. So is that it for the bad news, that we're starting to see a lot of Pseudomonas is bad, E. coli is bad, Klebsiella is bad? Now we're starting to see it in other places too. Next slide. I just thought I would throw this in because as I was going through the talk, I saw a recent report on the cosmopolitan microbial transmission of tuberculosis. Tuberculosis, geez, haven't we been fighting this forever? This has continued to be a global health concern. Recently, a report describes 7 cases that were transmitted through kind of intimate travel. So we're seeing this still not isolated within one specific group, whether it be virus, whether it be bacteria, gram-positive, gram-negative. We're seeing this across the whole spectrum in fungi, in parasites, in all types of infectious disease process. Next slide. So what can we do? How can we help? We've got no antimicrobials. What can we do? Next slide. Well, if we don't have the drugs, some of the things we can do. Forward, or next slide. Non-pharmacologic measures. Next slide. Antimicrobial stewardship. Continue. Protocol-driven treatment plans. And infection control processes. Next slide. Oh, and I'm sorry, the one that I forgot. And this is probably going to be one of the hallmarks of the whole talk, if we can remember this, and I know I'm preaching to the choir, is education, disseminating this message of what little resources we have. Next slide. Antimicrobial stewardship, just as a bit of a refresher, this collaborative effort, really kind of detailing the best way to select and use antimicrobials. And the goal primarily improving outcomes within patients, minimizing toxicity, minimizing other collateral damage that goes along with the use of antimicrobials, such as the development of C. diff, as well as the acquisition of resistance. Naturally, when we use antimicrobials better, we always get hope for that other benefit, the secondary goal to reduce healthcare costs. Next slide. Stewardship, again. IDSA developed guidelines in 2006. Panel with all kinds of really smart people, physicians, pharmacists, nurses, infection control practitioners. They took all the principles and they came up with what's the best infection control practices, what's the best way to use all the information we have to make a good plan for managing the use of antibiotics. Most of the data that they derived was set in the intensive care setting. And they could see kind of a cause and effect and how their work really played within that kind of smaller setting. One of the issues with the stewardship that we are seeing, it does get a little bit harder to make some of those principles. I'm not saying it can't, but it does make it a little bit harder making those apply in the outpatient setting. There are many more factors in the outpatient setting that certainly influence resistance. And when we go from an ICU to an outpatient setting, naturally there are things that are out of our control. Next slide. Key recommendations: formulary restriction, de-escalation of therapy, and I'm going to go through a brief study that talks about duration of therapy, IV to PO conversion. I always say the worst places to have a patient is to have them in the hospital. So if we can get them out of the hospital, keep them away from everybody else who's sick, that's even better. and again, reinforce infection control practices. I think that is one of those things that does not get enough attention when we talk about it. Next slide, please. So, ATS and IDSA, in the hospital-associated pneumonia algorithm, and I thought this was really important because I think this is potentially one of the ways that we're seeing, and because of this study, combating and lowering the risk of infection and curing our patients, providing the better outcome with eliminating resistance. What the treatment looked at was the difference between treating hospital-acquired pneumonia or healthcare-associated pneumonia with 7 or 8, actually I believe the study was 8 days worth of antibiotics versus 14 days worth of antibiotics. And as I was going through working at University of Illinois and Loyola, and for all those years, we always did everything for 14 days. My mentors told me every pneumonia gets treated for 14 days. What the studies and what the guidelines have shown is actually the shorter courses, the 7 to 8 day courses, are as effective as those longer durations of therapy that we've always become accustomed to using. And I think part of the thinking was if we treat long enough, we'll end up eradicating whatever organism we're worried about. But what we're seeing is outcomes are the same with shorter versus those longer infections. We're also seeing that in those longer infections, when the patients are reassessed for the acquisition of resistance, we're seeing resistance develop higher in those groups that are treated longer. Because of this and other similar studies, we're now seeing that we can treat intra-abdominal infections shorter. I believe it's 3 to 5 days now. We're also seeing that we can treat other cellulitis as well for shorter periods of time. So I think using these guidelines, developing protocols, and letting providers know that shorter can be better may be one of the main things that might benefit a treatment of a lot of the different infectious processes we see. Next slide. There was a question, are we ready for 3 days therapy for CAT? Some exciting data coming out. I can't wait. And 3 days for community-acquired pneumonia, I would love to see that. And I think we're starting to see more of this. And I think, again, there's nothing sexier than figuring out how little can we use and how much can we conserve to treat the patient and have it be a good outcome without inducing resistance. So great question. I think that this is really kind of pushing that what we have left for leverage to treat some of these patients. I think that these shorter durations of therapy are going to become more the rule than the exception. Infection control process, something else that I think typically gets glossed over. And I do, and I know I'm speaking to infection control people, and I'm a microbiologist. It sounds like such mother stuff in a way. Wash your hands. Do this, do that, and it sounds like such common sense. But we really know, and we've seen from the spread of virus, the spread of flu, and everything else from this last pandemic that we went through, we've seen transmission and other things go down. Why is this? It's good hand hygiene. It's isolating those people that are sick. It's screening for those people that are sick. Once we identify them, once we get them where they're not at risk to transmit to other individuals, or if they do, and those individuals that have contact with them take proper precautions to make sure that they're not transferring anything infectious. I think this is another one area that we really need to concentrate on that oftentimes doesn't get the attention that it deserves. Next slide. So really, in summary, we don't have a magic bullet. I know that there are some experts on this presentation, and maybe they could provide their 2 cents. I don't see anything coming to the pharmacy, to inpatient, or anything that's really going to change the way that we treat a lot of these infectious processes. We just have to use what we have, and what we have to do, we have to use it better. We have to use shorter courses. We have to use the drugs more effectively, whether it's through pharmacokinetics or pharmacodynamics. We have to figure out how to get everybody on the same page. When we have these protocol-driven plans, does this make it easier for everybody? If you come in and you're getting treated for 3 days for community-acquired pneumonia, that's enough. We don't need any more. Next slide. Infection control practices. Again, I think, the isolating, the hand washing, and all that, and we've really seen the benefit that it's done with the past COVID pandemic that we've faced. That is certainly principal to all this. And education. We are all and I know that I'm preaching to the choir. I'm around a bunch of individuals that really take this to heart. And I think that we need to let everybody else know that when your friend says, you know what, I need to go talk to my provider because I think I need a Z-Pack. No, you don't. We have to really change that attitude, and we have to let everybody else know the problems that we're facing. Not only the patients, but the other providers, the other individuals that aren't as intimately involved in the infectious disease process and the infection control process that we are. So, in short, kind of getting on our soapbox and making this our next crusade. Next slide, please. So I really date myself because I put up a slide for any questions with Arnold from Horseshack from Welcome Back, Cotter. I'm going to have to find somebody else who's much younger because everybody knows that I'm can kind of guess roundabout when I would have been born. So thanks. I'm sorry for the technical difficulties and the glitches at the beginning of the talk. If there's any more questions, I'd certainly like to open up a discussion. If anybody has anything they'd like to comment on and say.
So there is a question or a couple questions in the chat box. This one says, could increased resistance in some countries be associated with OTC access to antimicrobials? Thank you.
Yes, I saw those and I tried to answer those as I was going through. I saw Dr. Chug's comment there, and I certainly think so. I certainly think that not only it's the duration, but it's the amount of antimicrobials, and that seems to be another one of the driving factors going is not only the stuff that we're seeing inpatient, and that's an easier one to measure, but it's that outpatient. Because that's where the vast majority of our antimicrobials get used. Again, I thought Andrew's question was really good. Are we ready for 3 days of therapy for community-acquired pneumonia? God, I hope so. I certainly think so. And he said some exciting new data coming out, so I can't wait to see that. Regarding outpatients, do you think very much resistance is driven by patients that do not follow their treatment plans, such as quitting antibiotics too early, taking them sporadically, giving them to others? I think it might have something to do with it. How much, I don't know. Because again, if you're that patient and let's say you're given the 14-day course for UTI. Nobody does that, but let's just go along with the example. You got 14-day course for a UTI. After 3 days, you feel good and you take the rest of them and you put them in your counter. I would say winner, winner, chicken dinner, because now we've already taken potentially 11 days worth of treatment, kind of pushing resistance in her or in the patient, shouldn't say her, in the patient who we're treating for the UTI. We're kind of maybe getting by with a little bit less therapy. You do bring up a great point, is that how many people have antibiotics thinking about when the zombie apocalypse comes? I'm going to have to hold on to these because when we're invaded by the zombies, I got to make sure I have enough antibiotics in my medicine cabinet to treat this if it comes back again. That's an absolutely great point. I know patients do share medications. I work in an HIV clinic, and I'm just always tell them, God, what does an aneurysm feel like? When they tell me that they share medications with their partners, I just don't know what to say. So to assume that they would do the same thing with antimicrobials, absolutely. And again, that's where the vast majority, I think, pound for pound, if you're looking at our usage, is coming from is from the outpatient setting. So great question. Anything else? Welcome back, Cotter. I used to watch that all the time. Thanks, Kim. Now I don't feel quite as bad. You're younger than I am, though. I'm going to say that. You probably watched it on reruns, though. Unfortunately, I saw it prime time. Anything? Bueller? Bueller? Some kind of DOO economics? Well, that being said, if nobody has any other questions or comments, do I just sign off, Shannon and Rachel?
I would stick around for a minute or two.
Okay,
People may
that's
be
fine.
typing, but yeah, you definitely don't have to stay until the end if you're not getting anything. And then this is the end of the day. I'm going to go over briefly how to get continuing education credits.
Yeah, no, I could sit here. I just didn't want to
Just
sit
give
here
it
and
a
awkward
couple of
sit.
minutes. Oh,
Okay,
no.
sounds
Thank
great.
you. Yeah, I agree with Sarah. I just saw her comment. Awesome presentation. I was very interested and thoroughly entertained the whole time.
Well, thank you. I like I said, I'm sorry about the glitch in the beginning.
Oh, that's fine. It all worked out.
I appreciate everyone's. I'm just trying to type, and I still I'm an awful typer. I can't type really. It's going to be the death of me. But I appreciate everybody's thoughtful comments and regarding the talk. It's very nice. Thank you.
We do seem to have one question from Kim that just came in. She's asking if you're seeing much resistance in pediatric patients.
I know that there are pediatric experts on board. Um, Most of the data that I have seen is aggregate data, meaning that they're taking a lot of pediatric as well as adults and glopping them together. So how much we're seeing in pediatric patients, I don't know. I would assume that there would be some out there, um, but I can't say for sure, and I don't know clinically how important it is. And typically, unless there's some underlying other disease process that's causing um, um, the PEDS patient to require, and I'm thinking about cystic fibrosis or something like that. I don't know, and I'm just going from my N of four, my four kids. My kids haven't seen a whole heck of a lot of antibiotics. So, I don't know if it's really driving it as much. But, again, I don't know. I couldn't give you a real good answer. Good question. Rachel and Shannon, did you see the comment about the codes for the CE?
Yes, and I linked the code underneath her comment, so hopefully she saw that before her computer restarts itself.
Okay.
If not, I can send out the instructions as a PDF afterwards as well. Okay, I think I'm going to head out. I think that might be all the questions for this session. Thank you so much, Dr. Schriever. I'm going to go and set up the continuing education instructions for everybody.
Excellent. Thank you, everybody. I appreciate your time.
Thank you. This was great.